evidence-based, increased hot topic medicine related efficient 70 of met and every second is the one who paper remember there are only 5 paper key component of evidence-based. Here is the okay, so then meta-analysis is a key approach in evidence-based medicine, and the Cochrane collaboration out in the world to related to prescription or treatment and nursing care should be scientific evidence-based or scientific evidence-based or scientific evidence informed. Institution, which is evidence-based nursing institution, studying nursing, JBI, launched in Cochrane. There are almost 100 countries joined Cochrane, and in Joanna Bridge evidence-based healthcare, there are 80 countries, 80 collaborators join Joanna Bridge. So it is a very internationalized research institution. It is, I think this person, this Professor Alan Pearson should be mentioned, because in the international history of evidence-based healthcare, there are, I think, three persons are very important. Alan Pearson is the one who launched evidence-based healthcare and proposed the model several times. And it's in Fudan University Center called 循证医学. Okay, and then we have the Journal of Evidence-Based Medicine, and also we have Fudan Evidence 2004 in Fudan University. That's the first research center of evidence-based nursing in China. We do hope that we could have a first evidence-based nursing center in University of Indonesia. Okay, so why we need to have evidence-based nursing approach, the philosophy of evidence-based nursing, knowledge and or needs, this first gap. So we conduct a lot of a qualitative study or experimental study to know a lot of basic applicable in translation science. Translation study can be applied into consider in nursing, because nursing are first line in healthcare. We consider the big gap is there is research published in nursing journal. There are hundreds of nursing journals, but the research there, but the practice is another side. It's another side, like hand washing, like all the adherence. We have all the guidance like hand washing and also infection control, but the reality is that hand washing and the infection control, the situation is not so good. Why it is not so good? We have the gap, the evidence and practice gap. So evidence-based healthcare focus on the third gap, to manage the gap. So so we are here from the clinic study to clinic practice. There is the huge needs for caring-oriented study, understand all the process, the barrier, the facilitation, all the resource, how to motivate people and to use the resources. So the process, the natural process of healthcare, we should understand all the human beings behavior and the attitude and effectiveness and efficient intervention healthcare. And from the definition of evidence-based medicine from Professor David Sackett and Gordon Weird, the group, they are in the group. Sackett is passed away, but the team, Gordon Weird, is not very active in update evidence-based medicine. One is best available external clinic evidence from systematic research, not only in single research, but the systematically integration of the similar research with the same population, same intervention, same outcome to integrate it together as using a systematic review approach. So that is the first expertise of our clinicians. Like here, a lot of master student and clinic, you are like, I know the final year of master students are in the clinic. So the clinic expert, you have the clinic expertise, you have the intuition option. So that's the expertise. And another one is very human beings, it's the patient preference. The human beings, the patient, their needs, their preference is really very important in we make a decision of how three elements from the definition is the best available systematic research outcome and also clinic expertise from our health professionals and our patient preference assessment, accurate assessment of the patient preference. So that definition is really very important because that is the philosophy of the value and the mission of evidence-based medicine in focus on the needs of clinicians and respect the clinic expertise. And also integrate here is internationalized collaboration because we should search internationalized evidence inherently and then make them and evidence synthesis approach, systematic review. And also interprofessional collaboration, because in the evidence-based healthcare, like the project we have, Professor Riri and Yati and the team in they have the interview with clinic partners in the hospital. We can see a lot of barrier. Just like in Shanghai, we have a lot of barrier, like the like exercise and adherence to exercise. That's really very important. Patient knows, family members knows, and our people, our nurse knows. But the real situation is that they have a lot of reason there and give them the motivation and improve their adherence of exercise. So we should have the collaboration with professionals like clinic nurse, surgeon, and also like rehabilitation staff to work together to make them understand how to exercise and what is the best way to exercise and what is the best way to record and what is the best way to improve the level of their degree of the exercise in a scientific way. So collaboration with expertise, with other professionals, and collaborations with international partners are really very important for evidence-based health. Information of evidence, how evidence can be applied into really real world. Here is a model we use in, I think it is a very popular model, a conceptual framework for evidence-based healthcare, developed by Professor Alan Pearson. I said he is really a very historic person in evidence-based healthcare. Her team proposed the model and then updated. So what is the mission of evidence-based healthcare? Global health is the mission, is the goal, the final goal of evidence-based health, to have everybody in the world, people, to have the healthcare, the best healthcare, global health, and the screening evidence from all the database. And then we do a synthesis. Synthesis means we combine different primary study results with the same, they have the similar population like breast cancer, the outcome of function, but publish or have the primary study published in different country, different journal or different place. Then we search to synthesis the results improved effectors because we imply sample size. So we use stage of evidence-based healthcare is transfer. So transfer when we first have the idea of transfer, it is a small thing. Transfer, I put this information to deliver this information to other person. That's transfer. But actually, in evidence-based healthcare, it is a very challenging thing to transfer evidence into individualized and into the organizational way. To individualize, we give the information that's enough. But for organization, there's a lot of barriers. Like the organization have their own policy, own regulation, own understanding is sustainable. So the transfer is very challenging things, and also it's a very innovative, transfer, human transfer theories to improve the accessible and understandable and system integration. We put the evidence, assess the feasibility, applicable appropriation, and also the meaningful and effectiveness, and then we integrate the evidence into the system of education. It's not just like education. Like today is I just deliver the education, a very good ways of education. Train the trainer, like in the hospital, in like demo is, if we just provide the evidence to patient researcher, we can provide a lot of information, a lot of evidence to patient, but it's not as sustainable, because we are research, and then we leave, train the trainer. We provide all the evidence, all the approach, all the system to nurse in Demarest or cancer hospital, and then they are clinic nurse. The evidence-based approach, all the package, all the resources together, integrate with their care, the daily care, with their professional expertise, and then that's the model. Is a patient is it's like a simple word but difficult process, because implementation is an innovation. It's a change. It's a planned change. A planned change, we need a change agent. A planned change, we need to make the traditional ways loose, make the traditional ways change. People like feel there is needs to make the traditional way change. That's very difficult, because people always say that what I'm doing now is very normal ways. That's my way. That's the way I was told. That's the way the organization was something happen there. If there is side effect, normal. That's human beings normal. So making change is not difficult. It's not easy. We need to have the facilitate to have a change agent, to have resources ready, and to give training, give education, and to have the roles and responsibility and function, all the pathway ready for embrace evidence. And then we evaluate all the process. We monitor all the process and evaluate the outcome. And that outcome is not only the outcome of patient, like the musculoskeletal skeleton symptom care. The final outcome is the pain assessment of patient with breast cancer when they have the endocrine therapy. That's the final outcome. But for evidence-based healthcare, we have secondary outcome. That is the health professional. Whether or not our health professional have improved value, improved attitude to exercise, or improved knowledge and the behavior of motivate patient, or of evaluate the outcome of exercise in a scientific way. So the outcome is not only patient outcome, but professional outcome and the system outcome as well. So 3 outcomes for implementation. So that make the research much complicated. So we normally use the MRC model to design implementation study. MRC model is for complex intervention. So that's the model. The key element is evidence, context, and clinic expertise and patient preference. And how can we improve all this process? In the middle of the model is FAME model. We call FAME model. FAME assessment of FAME model is to assess the feasibility of the implementation, the appropriateness, whether or not it's cultural adapted, and also meaningfulness, whether patient can accept this, happy with the intervention, and also effectiveness of patient symptom improvement, symptom change, or symptom management, and also their final healthcare outcome. So that's the model. I think there are a lot of information in that model. From that model, we can see evidence-based healthcare is not a simple process, not evidence and practice in a direct way, no direct way. It's a very, very complex process, and we need to have like assessment and then make decision, and then reassessment and then make a decision, all this complex process. So we have the pathway. There is a pathway of evidence-based healthcare. We start from here, evidence generation, from primary study, and then we do evidence synthesis with situation analysis, identify process, and define all questions using PICO, P-I-C-O, or P-E-C-O, or P-I-C small o, and then using the PICO with the keywords to search the literature, and then we assess critically assess the quality of the outcome. If the quality is very good, we're continuing. If it is not good, we'll go back to have primary study. If the study is with good quality, we are going to do the systematic review continuing, and that's all the synthesis. And then we have a level with the systematic review, we're continuing could have the level of evidence and the grade of recommendation, the grading system. That's the key characteristic of evidence. It's a hierarchy. Evidence have the hierarchy. And then we do the evidence dissemination of care manager or practitioner or patient or decision maker. And then the final stage is implementation. Implementation is not only, it's not a simple process. We need to have the localized a protocol, or to do a lot of training or leadership to facilitate the process and implement and evaluate the outcome, and embed all the process with evidence integrated into the practice. And that's not a final point. It is just the one stop of evidence-based healthcare. We need to continuing assess the practice again, and it might have new problem with the current evidence. So we need to assess it continuing, and then we will go the circle again. So that's the circle. So here we are in Indonesia again. We're going to discuss with Professor Yati and Riri whether or not our previous musculoskeleton project can have the second round of implementation, like whether or not we should have AI in the process of encourage patients to do adherence. Okay, so that's the model of evidence, the pathway. So we have the model, and then we have the pathway of evidence-based healthcare. Then the implementation can follow a concrete and easy understandable ways, because it is such a very complicated process. Very important characteristics of evidence. One is what I mentioned, hierarchy. Evidence is with different hierarchy. There is a pyramid of evidence, and it is coming from different resources. So evidence is a word with pluralism, the philosophy of pluralism. That means different design can contribute evidence. Not only in RCT, not only randomized control trial can contribute evidence. Even our qualitative study or observational study or like or diagnostic accuracy study or like expert consensus can also contribute to evidence. So it is the resources coming to very rich resources can contribute to evidence, but it is not equal to evidence. It can contribute, but we need to do the assessment, need to do the quality critical appraisal, we need to do the systematic review to synthesis. Then the research outcome and evidence can have the equal way. And then it is context related. The way we produce evidence is context oriented. It is very related to the accurate context. And another side is we apply the evidence is in another context. So it is evidence, all evidence is very context related. So when we apply evidence, we should consider where is the evidence coming from? What is the context when the evidence is proposed? So what is the original study is talking about? Where is the context? What is the context attribute? So context attribute of the evidence. And then it is changeable. Evidence can be changeable because of the improvement of technology. So the evidence, just like CPR, when we first been training CPR, we use ABC, airway first and the breathing second and circulation third. That is the guideline for the 2005 CPR guideline, ABC. But from 2005, the guideline totally changed from ABC to CAB. And everything, a lot of things are changed. So every time, every 5 years, we will see how the CPR guideline is changed. So we accept evidence can be changed because of a lot of new research can make the reality, we assess, we go close to that reality. So it is dynamic, it's changeable. So we don't consider it like strict, not strict, nothing is strict in evidence-based healthcare. Everything is flexible with the appropriate approach or method behind. So it is flexible, but we need to assess it in a very scientific approach. So pyramid, the hierarchy of evidence is present by the pyramid. From the pyramid, you can see evidence coming from primary study. We have different design of primary study. We have RCT, like a very restrict, very good design of randomized control trial, but it is not easy to carry out. And if we cannot have randomized, we have controlled clinical study, or we have cohort observational study, or we have cross-sectional survey, or we have case theory, or we don't have time, we don't have resources to conduct the study, but we have consensus, we have professional consensus. So that's the in nursing, because nurses do not have prescription, we consider a lot of consensus or guideline. Then that's the decision-making first resources. But because of evidence-based medicine approach is proposed, people's professional value study outcome to the synthesis of studies with similar design, similar patient, similar intervention, and similar outcome. To make it integrated synthesis, use our systematic review. And then we need to have, because they are in the area like breast cancer, exercise, and also infection control, there are a lot of guidelines. There are hundreds of systematic review and guidelines. How can we effectively use these resources? Then we have the synthesis of systematic review. So we have clinic practice guideline, And then we have summary of evidence. And then finally, we have the decision-making system, decision support system. Using AI now is make everything very making everything very very quick way. But if we follow all the process, because we know AI might have evaluation, just make decision, use whatever AI can search. That is not the way we want. We need to have the make decision, use the scientific, people controlled, and have the transparency process. So that's the AI process. And now it's so quick. The evaluation is the problem, but I think evidence-based practice is a very good start to go beyond or to manage the evaluation issues of AI. So decision support system. We need to have a lot of approach of the knowledge base. We control the knowledge base and we control the process of AI search and AI make decision, because the resources we can control. So decision support system is a way to make it effect, but also very effect quick, but efficient. Okay, so the hierarchy, it's the very good, I think, attribute characteristic of evidence-based healthcare. So there is level of evidence. There are different evidence-based healthcare organization propose the hierarchy. Here is the level proposed by Oxford. That's in the year 2011, but now the evidence hierarchy system, now current people all use the hierarchy system is great. Great system is to make the quality of evidence based on the assess of the systematic review. To say it is very low or moderate or high depend on the research. Is change the confidence in the estimated effect or not. So that's the first characteristic is the hierarchy. And the second one is the pluralism of evidence. Just like what we say, evidence can coming from the systematic review of RCT, and also can coming from the systematic review of expert opinion, from descriptive study, from cohort study, or quasi experimental study. So coming from different resources. So the pluralism. And the third attribute is the context related. So when we apply, try to search evidence and try to make it integrated into our system or try to apply, we need to assess the feasibility or appropriateness, meaningfulness, and effectiveness of the evidence implementation. So that called FAME assessment. So that's the whole process, the pathway, very important steps in the pathway. And then the dynamic. So we need to, when we consider it is evidence, we should add it is evidence of where or who published, who issued the evidence, and what is the year they issued the evidence. Because that is very important, because like intravenous management, IV management, we have the evidence from INS, US INS, but that one is changed every 5 years. So there are a lot of very totally changed things from INS, intravenous management evidence. So we need to have the updated evidence. So we can search a lot of guidelines from the resources like GIN. GIN is the international guideline, international network, from NICE, from UK, NICE, or Scotland, from SCI is a guideline network. And US, they have NGC, and Canada, they have RENO. RENO is Registered Nurse Association of Ontario, RENO. All these organizations, they produce a lot of good guidelines. They are healthcare, evidence-based healthcare organization. And also we can search guideline also from the professional association, like we search gerontology association, we can search a lot of guideline on palliative care. And American Heart Association, we can search guideline of CPR. And UN National Care Guideline, when we have the pain management study, we find the guideline from NCCN, the different resources. So that makes every health professionals need to have the open view to the information system of professional information system. So here is the list of this guideline in information system. You can find it. Then another model of implementation is we call sunrise model of evidence implementation. It is developed by our research, our team from many studies. We developed this model, theoretical base of JBI model or evidence ecosystem and the quality control model and implementation science, and from 70 JBI fellowship program and 110 evidence food and implementation project. And then we have this funding from Shanghai Health Bureau, and we use the method of conceptual analysis and serial deduction and empirical data refining and then finally expert consensus to develop this model. This model just mentioned that evidence-based implementation, just focus on implementation. It is a goal of continuing quality improvement. Like we have this first cycle of pain management for breast cancer patient, and then we should have the continuing of the goal, and start from scientific evidence, and then we use multidisciplinary team to conduct the project, and using the project management approach to implement evidence. From this process, we can see the different level. The first level is the preparation. So the preparation is, I say, we need a lot of time for preparation, not just start and doing. Start, prepare, and doing. So the preparation, we need to have the scientific theory preparation of the value, change of mission or vision of value. And then we have the question. We have the clinic question and then the research question. So PICO is the research question for evidence-based medicine, but PIPOST, P-I-P-O-S-T, is another ways of proposed questions through implementation. I will talk about PIPOST in a detailed way later. And then searching and the critical appraisal and evidence summary and the context analysis. So that's the preparation, long process of preparation. And then the second circle is to do the implementation. For implementation, we need to have the evidence change it to the audit, clinic audit indicator. So the indicator can make our clinic quality improvement quite concreted, can workable, operationalized ways. So audit indicator. So just for our breast cancer project, actually we have more than 20 evidence piece by piece, but more than 20 is too much. When we do the implementation, we need to make it simple. So finally, we have about 12 indicators for clinic to implement. So make it shorter, and all the indicator is very short way, easy to operate. And then we have the evidence, have the goal. The audit indicator is a goal. We have the evidence, we have the goal, and then we need to assess the barrier, assess the human being, policy, resources, all the things, and then making change, and then have leadership ways, have the hierarchy, the leadership ways to to motivate, to make it sustainable, and then facilitate all the mobilize all the resources. So the second stage, because it is a research, we need to have so we use that implementation science approach and implementation research method to end all the process, to have the design, and then to measure the outcome in terms of the patient level and health professional level, and also the organizational level outcome, like the symptom change, the symptom policy change, the pathway, if there is pathway for that specific question, solving the problem. And then the final stage is sustaining and maintaining. Remember, because it is a quality improvement process, there is no stop. There is continuing, we need to have new question, new program, and continuing to have new evidence to improve and make it sustainable in the practice. So all this is go back to preparation. If we have new question, we go back to the preparation, go to a second round. So that's the model of evidence implementation. I think tomorrow or the day after tomorrow, we will share some example of evidence-based practice project, like the one we have collaboration with Faculty of Nursing in Indonesia, and also some of our multi-centered study in Shanghai, or in China. Actually, it's not just in Shanghai. In China, we have more than 20 centers go together to conduct an implementation process. So that's I think I can share that in tomorrow or day after tomorrow. Here is the implementation. The theoretical base underpinning evidence-based healthcare is implementation science and implementation study. So what is implementation science? Here is the first proportion of implementation science in 2007. In Science, there is a publication by Modern called Public Health and Implementation Science. So that's the first publications propose the term implementation science. So what is implementation science? They said implementation science is a study method to improve. There is three keywords: uptake, implementation, and translation of research findings into a routine or common practice. So that's the update, how to implement, how to uptake, how to carry out, and how to translate the evidence from the publications into clinic setting. So that's the know and do or evidence integration of research finding and evidence-based intervention into policy level and practice level. It is a valuable tool. It's a tool. Its approach is a value and a philosophy and a tool and the process that used not only to improve program effectiveness. Effectiveness is patient outcome, but also explain how it can be work and what is required to make it work and what is required to make it sustainable. And what circumstance, what is the context, what is the different context, they have different, what is the specific characteristic of context. So I think it's considered a real world study. So for implementation research, we use a lot of evidence. I mentioned evidence-based medicine is Cochrane Library, use systematic review, it's the meta-analysis logo, and evidence like hierarchy, the pyramid. So implementation research, not science. Science is a big head, and implementation research is a scientific study method to promote the systematically the three keywords: update, implementation, and the translation of evidence of research findings and other evidence-based practice into a routine care by developing and evaluating the practice solution. So that's really very important, solution, because one evidence like hand washing before all procedure, but different solutions for hand washing, for the adherence of hand washing. Somebody just said, keep watching. Somebody just said, there is a place when you stand here and then you open the hand washing, and then we know that you are hand washing. So that's different ways to monitor hand washing, to implement, to make the solution, to have the smart solution or effective solution or innovative solution, and a critical problem in the implementation of the intervention, and hence to improve the quality and effectiveness of health service and care. So that's implementation research. The keywords that it is a research. It's not just doing something. It is a research method of implementation something into practice. So the keywords is also implementation science keywords, uptaking, implement, study. Okay, so when we have implementation study, we start not PICO, but PIPOS. That's the improvement of PICO. PICO is evidence-based medicine. We start with PICO, the question. And then for implementation study, we have more things, more elements in PICO. Population, intervention, series of intervention. Like in breast cancer exercise, we have intervention of knowledge, of monitoring, of evaluation of the dosage. So the package of evidence for one specific program and profession, who will carry out, who will assess, who will control the quality of context. What is the setting of implement? What is the human power, the resources, the find the evidence support? What is the level of evidence from the evidence pyramid? It is a higher level or lower level, and what is the grade of recommendation and a level of evidence from the one we are going to use. So make it transparency and a systematic way. And then remember, it is a study, so every study need to have the design. What is the what is the design of the study and the setting, and also the data analysis, data collection, all the process. So steps of implementation science need to have like context and data and dissemination research findings and monitor and evaluation the process. So that's the process of improvement in or for our health manager, head nurse. We need to consider the intervention, everything influence practitioner. Is the health professional have the responsibility and have the responsibility and also willing to do this? So the preparation of the individual, and also the process of the implementation, and the inner setting, the context of the organization, the culture, the structure, and the network, and outsider settings in terms of the economy or social or other pressure. Like here, AI now, whether or not it is strongly influence our process, strongly influence our professional behavior or unprofessional ways. So AI is there. So that's the pressure for us. Like currently, every research we should consider AI, whether or not AI the factors we need to consider. So you can see that evidence-based healthcare and implementation science is not so difficult. It's very easy, but it is really difficult to carry out because it is so many factors influence the process. So we need to have three key analyses, context analysis, gap analysis, and FAME analysis. So that's very important analysis for preparation of implementation science. Analysis on context analysis. And analysis, the practice and evidence, what is the gap there? So the gap analysis. And then analysis the feasibility, appropriateness, meaningfulness of the implementation. That's the FAME analysis. So that's very make the process very complicated. And we need to have encourage and maintenance of evidence interpreting of the evidence to make it make it looser. We need to have a lot of strategies to interpret interpretation of the evidence and using project a short time limited ways to try to have the try and to have job description and adjustment. Like if we want to have like ICU patient with with machine with all the monitoring, make them stand up, make them doing exercise. It's not so easy because safety is an issue. So for the rehabilitation in ICU, we need to have a person, have a nurse who specialized, have the job description about rehabilitation for people with ventilator. So that's the job description. That's the task adjustment of the task, the responsibility of ICU nurse. So that's the change. Encourage and maintenance. We need to have the leadership ways to maintain, motivate, and mobilize all the resources, and the training and the system optimization. Like the people have more, like ICU nurse have the routine care, but in addition to routine care, she has the additional extra responsibility for rehabilitation. Then the job description changed and the performance evaluation need to change accordingly. And also the payment, the income of that nurse need to have higher income because he is very higher technology and higher knowledge required. So the training and the system optimization is very important. So it is not just research. It is go beyond research. We need to have a system come together to discuss the same issue and to facilitate all the process. So to evaluate the primary study, we just evaluate the patient, whether or not level of pain is reduced. So that's the primary study. Traditional evaluation is the patient outcome. But for implementation study, we need to evaluate a lot of things, not just effectiveness of the patient outcome, but the whether or not richness, that means the evidence is reachable from health professionals. I can't move. Can you move it from me? Just it. Cannot move. Okay, here. Another one, previous one. Okay, here is the reach. Reach is the make it who can assess the evidence, and effectiveness, the traditional ways, patient outcome improvement, and adoption, that's uptake, adoption, and implementation, and also maintenance. So we evaluate not only effectiveness of the patient, but the system reachable and the health professional adaptation and implementation, and also the system level in maintenance. So very complex process of implementation. Then for implementation study, we normally use mixed method of design. So we call it hybrid design of implementation study. It is the newly proposed approach by Professor Landis in the year 2019 in psychiatric research. So it is in psychiatric research, not in not in nursing or not in public health, but in psychiatric nursing, using an introduction of effectiveness implementation hybrid design. But that paper is highly cited. So if you come to download that paper and read it, you will learn a lot of like new approach, new philosophies to implementation study. From that study, they said these are hybrid. Hybrid means the mix of effectiveness evaluation or implementation evaluation. If we just evaluate the efficacy, that's the very traditional ways to affect the patient outcome. So for the efficacy study, everything should be controlled, like RCT, only the intervention and the control. Other things like the patient sex, patient education, patient like the severity of the disease, we need to control that one to compare the intervention group and control group. Control their severity of the disease. We use a grouping method to control it. So that's the efficacy study. But in the real world, it is not so easy because to control so many things, it is not easy. So that's the efficacy study. That's in the very experimental ways. But in the real world study, there is two types. One is to evaluate effectiveness, and another one is how it can be carried out. That is implementation study. So from the one we have in breast cancer one, we are in Shanghai side, we are actually the implementation study because the evidence is there. It's in NCCN. NCCN, the evidence is there. What we consider a lot is how can implement in Shanghai, in Jakarta, in Dali, different cities. So the implementation is our primary outcome. But we are now carry out another study, similar musculoskeletal Ethiopia. One of my postdoc students is carried out in Ethiopia. There is very different in situation. So we are consider more on effectiveness in Ethiopia. Not implementation outcome, but the primary outcome is effectiveness outcome because the resource there is so different from other place. So we have effectiveness primary outcome and implementation second outcome, that hybrid one. But what we have in Jakarta, in Shanghai is hybrid 3. We consider the effectiveness is there, but we consider how can implement so that the second hybrid in Jakarta and hybrid 1 in same study, hybrid 1 in Ethiopia. And we have another study tomorrow or the day after tomorrow I will share is implementation hybrid 2 study. That means we have the evidence there, we have the implementation there, but what is a package? Intervention. How can we put the required or most necessary solutions in strategies in the process of implementation? So that's the hybrid 2, have effectiveness and implementation together. The same equal level of implementation and effectiveness because we changed the component. We have the rearrangement of the component. So we need to assess the effectiveness and also the implementation. So that's image hybrid 3. So we can see hybrid study is not the concept of mixed study. We know mixed method study is a qualitative study and a quantitative study mixed together. That's a mixed method. So that's the qualitative and the quantitative. We can have qualitative first and a quantitative second, or other ways, or we have other different ways of mix. That's a mix of quantitative and qualitative. That's another concept. Here, the hybrid is the hybrid of effectiveness and implementation. So it's a different approach, not the mixed method study, because a lot of my students, they ask the same question: is it hybrid similar to mixed method study? So I think different approach, different thinking, different ways of thinking. It is a mix of effectiveness or implementation, but that one is a mix of quantitative and qualitative. So different. Okay, so I'm going to the end, have question time. The design, there is a different design, like the step wedge. People may see the step wedge, the design. That's a very typical implementation design. We have the first site, go to the intervention first, and the second month, second site, and then go step by step. So that's the ways to step wedge one for implementation science. RCT is sometimes questionable for implementation study. Why? Because RCT, we need to have the control and the intervention. So because it is evidence, why the control group don't have the intervention? In an ethic issue. So when we consider it is already very high level evidence, we use traditional RCT might have some ethic issue. So we need to modify the RCT to step wedge RCT or randomized control and waiting list RCT. That means our control group might have intervention later. So that's the step wedge one. Okay, I don't have time for the question, for the example. Tomorrow I will share 2 examples, but I just quickly say that here is in ICU, we have an implementation study of the patient, the eye care for ICU patient with a ventilator. So just very simple way, the eyes not closed very well for people with a ventilator. And then we search the evidence, and there is a lot of evidence like the eye care using the plastic cover, very easy way, very cost-effective ways, just to make the infection of the eye totally reduce the rate. And then others evidence is there, we just implement into our practice. So because of the time, I'm concerned about the time. I leave this because I already give some example during the process. I will stop here and leave some time for question and answer. Thank you very much.
Okay, thank you very much for the insightful and really thoughtful presentation for Professor Hu. Yeah, I know everyone is here have so much question in our mind, right? Before we move to the next speaker, I would like to invite the audience just write down 1 question or 2 about practical challenge from your own setting, and please keep these questions later, because we will use them later in the discussion sessions. Okay. Okay, ladies and gentlemen, Professor Changron Yuan, PhD, FEEN, Director of the Research Center of Patient Experience, Fudan University. Prof. Changron Yuan will present the topic Digital Health Management Integrating Pros. This session will provide valuable insight to how digital health can be utilized to support patient-centered care through the integrations of patient report outcome or pros in healthcare management. The floor is yours, Prof.
Good morning. Good afternoon. Thank you very much for having me here today. I'm Changrong Yuan, full professor of nursing school, Fudan University. To be honest, I've long been engaged in.
Oh yeah, barusan ditanya Kak Uli.
Okay. Nursing disciplinary construction and the research cover the chronic disease care, nursing informatics, patient reported outcome, long-term care, some issues. And I know that today the majority of the audience in this classroom are students. Okay, so you must think a lot about your thesis. So let's draw a general picture about the research. So what is research? So research is a roadmap from question to solution. So for our, as a teacher, we need to, help students to improve three kinds of abilities. Ability one, you know how to select a good topic. So select a good topic. Then second, the ability to design. So we will provide, we will deliver a course about how to do research design, quantitative, qualitative mixture method. So that's the ability two. For ability three, I mean the third ability, we hopefully we hope our students can improve. That is the ability of reporting their findings, the writing. How to write a proposal, how to write an article, something like that. So about the whole picture of the research, say we will start from how to select a problem, which means anything in clinical setting puzzled you. You cannot answer it. And after literature review, you cannot find the existing evidence to, explain it. Then, congratulations, you find a good research questions. So we hopefully we keep talking to students that you need to improve your two abilities. That is then my experience that is whole research pictures start from name the the phenomena you find in clinical settings. I mean concept development. That's the first thing. Concept, give a name of the phenomena you saw. For example, I know today is the public days, and we feel very, how to say, guilty, feel blame for having you here because you cannot, enjoy in the blue sky, the beautiful weather, but instead of, running in the beautiful campus, you have to sitting here. So, what's the, terminology to describe our this kind of feeling guilty? I think it's too serious. Then self-blame, or sorry, or feel impressed by your passion for the research. Say something like that. Develop a concept. That's a second step. That's the third. After develop a concept, you need to provide the measurements. Okay, develop a scale or questionnaire. Okay, the second step, measurement. Say later, I will talk about the data, because we need a tool to capture the data. So measurement, the questionnaire is very important. That's the step 2. Step 3, you got the measurement, then you do investigation, cross-sectional investigation, longitudinal investigation. You understand the situation very well. So the step 3, in investigation. The step 3, from those data, you need to find the ruler to create a theory, a model. The model, like what Ding Hu said. Okay, so usually we have 2 models in our research map. So one model is the existing model created by other people. We need to find a good model, a framework to guide your study. Okay, so that's find a good research model. As a reviewer, we usually said, I don't think the question you asked be supported by a good model, something like that. So you need prepare a lot of theory, a lot of model. And the other thing, eventually you need create a new model. So for PhD students, for PhD thesis, eventually you need to, contribute, create a new model, to develop a new theory, to help other people to understand the world more. Okay, so the step 4, you need to find a good theory, or you create a theory, then you test, prove the theory. Okay, the step 5, you know everything well, then you need to create an intervention. Manipulation, you need to create an intervention. Then next step, you need to test. So RCT or original study, experimental study. The next step, you publish a paper, and your intervention became a good evidence. See, the next step is evidence-based study. Your outcome the same with other people's outcome. So systematical review, meta-analysis, something like that. Then next step, we have a good evidence. Then we need to imply. Then implementation science. Okay, step by step. That is the whole picture of the nursing research. Hopefully, together we explore more in this research. Then we should say data. Data matters in these big pictures. So where the data comes, a lot resources. One is from the lab. When you go to the clinical, the doctor will say, okay, tell me what's wrong with you. You see something, then say, okay, do some test. So the lab will contribute the data, and the doctor and the nurses, they will provide their professional activities. Then another data. We still miss a data. What kind of data? Yeah. The information from patient themselves. We call it a patient-reported outcome. Okay, so today I'm talking about this kind of data. I'm not saying this data will extend other data. No, they just working together to make a good decision making. So totally, they are different data. Thank you. Like say data. No. Oh, okay. 我用手没事。Data reported by clinicians, data from physiological lab, and the data reported by nurses. Okay, we are very familiar with those data, but for data reported by patients, including families, usually we missed it. We did not give them very important status. So since 2004, there is activities across the world. We call it listen to the voice of the patient and empower these voices. So what is listen to the voice of the patient? So patient's voice, we call it patient-reported outcome. So patient-reported outcome is a measurement of any aspect of a patient's health status that comes directly from patient without the interpretation of the patient's response by a physician or anyone else. Like, are you sad? Are you unhappy? You suppose not so pain, something like that. That's not true because they decided their experience. So why pro matters? Because some treatment effects are known only to the patients, and the patients provide a unique perspective on treatment effectiveness, and the formal assessment may be more reliable than informal interview. So after knowing what is PRO, then we need to measure it. So I'm introduce three definition: PRO, the next PROM, patient-reported outcome measurement. So there are a lot of measurement. I heard last night, yeah, Adam, and yeah, you came to airport to pick us, yeah. Even yeah, you mentioned in your thesis you use a lot of questionnaires to collect patients data. Say I mean different measurements can contribute different data. I'm trying to say that there are a lot of measurements. But today I'll introduce one measurement system that is PROMIS, promise, patient-reported outcome measurement informatic system. Okay, so promise, that's the three-level definition. Then for promise, why I agree and devoted so many years in this area, because they have several characteristics. First of all, when we talk about the measurement science, okay, there are a lot of techniques. Today, I have not enough time to describe the detailed technology, but I'm trying to say that in this system, they try everything in this, try everything. I mean, in theory and in technique. So that's a multi-disciplinary group, like nurses, physicians, methodology, statistics, and the informatics. So they work together to create this system. So in 2004, it started by NIH. Then gradually it developed as the whole world, the organization, international organization. The name is Promise Health Organization, PHO. Okay, then let's say
what's different from this measurement system? It included, as a human being, their feeling supposed to need to cover 3 areas: physiological, psychological, and social. Traditional measurement, we will hypothesize that patient in this situation supposed to have like 4 kinds of experience. Then I bring 4 variable, 4 measurements. That's enough? No, you may miss something. So for this system, they don't hypothesize. They just bring the whole measurement. Okay, they bring the measurement bank. We call it item bank. For this item bank, people's experience, people's feeling regarded to physiological, psychological, social, all are there. You just bring the whole bank to do the measure. Totally, for this bank, research continue to continue. So the bank become bigger and bigger. We don't want to miss any people's feeling. So when we figure out one, then we introduce one into this bank. So far, for this bank, totally, for this bank, say, so three frames, physical health, mental health, social health. So every year, research just put their new findings into it. So every year, the measurement system are different. So far in this year, there are more than 2,000 items, which means we won't miss. Okay, we won't miss. But you may say, wow, you do a research. You need to ask patients to finish the questions more than 2,000. That's a huge research burden. Am I right? Huge research burden. So what's the solution? What's the solution? They have three. They have three the tool categories. One is short form, which means core items, and second, profile, which means very special areas like breast, like stomach, so very focused the profile. But very important is the CAT, capital adaptive tests. So CAT is the best way, which means you have total bank, but for every single person, they don't need to do them all. So when you do the first item, you finish the first item, your answer will determine which is the next item. How to explain? Let me do a little game. Okay, let's do a little game to help me to explain that. Who want to be the volunteer to help me to moderate? You are good host. Okay, let's do Rula. Okay. You're very wonderful. You hosted the conference very well. Let's do a game to help us to understand the measurement. From 1 to 100, 100 numbers. You pick one in your mind, keep it in your mind, okay? I will guess the number in your mind. You help me to count how many questions did I use to figure out the number, okay? You already make a choice? Yeah. Okay. Is the number larger than 50? No. So the first question. The 50. Okay, it's larger than 40? Larger than 30? No. Larger than 20? No. Larger than 10? Yeah. Okay, which means 10 to 20. Okay, larger than 15? No. 14. Yeah. 14, yeah. Thank you, thank you, thank you. Count how many questions did I use? 7. 7. Why? Because I have a ruler. Okay. When you said no larger than 15, so all the 15 numbers deleted. Okay. Which means when people have this kind of trouble, they won't have this one. When people have this kind of experience, they might be have that one. So they have a lot of linkage. They have the ruler. So when the research data are big enough, is big enough, we can find the rulers. Then this CAT, computer adaptive test, solve that, which means the item bank, they are more than 2,000. But for these patients, after answer the question 1, okay, maybe number 280 come with the next number, okay? So for each person, they have different items. In United States, one hospital's average, the patient will answer 13 questions. It took 2 minutes to finish that. No missing, okay, no missing. Okay, based on the psychological, physiological, social. So item bank are huge, but for the measurement are precise. Okay, that's the logic, that's the philosophy for this measurement. We can call it big data driven. Big data driven, precise measurement. Okay, then for this measurement, so many things need to do. So tools are not matters. Our focus are how to use these tools to answer your research questions. So three things we did. The first, tool development, because in different cultural environment, the items change. So first thing we do tool development. Second thing, incorporating tools into clinical routines. The third thing is integrating PRO data with multimodal data to drive new practical models. That's what we did. So let's see what we did. The first thing is, this is for this measurement system. The more the data we have, the precise the measure will be. So we have a good research team to follow that. Say that's our team. We have a lot of PhD students, post start and master, and that's our research team. And based on PRO, we, under the patient health, promise health organization, the practical model is national center. For here in China, we have the PNC China and promise health organization. I mean, a lot of national center. In China, we have a Chinese center. And Japan center and other different country. So in 2018, in Fudan University, based on the PRO data, we developed the research center. We call it a patient experience center. And that's we call the Promise National Center China. And then in September 2019, the PNC China was launched officially in Shanghai. She is the vice chancellor of Shanghai Medical Center, and she announced the launch of the PNC China. Then what we did is, we encourage groups from the whole country. If they are interested in this measurement, they can ask their requirement. Then we sign the we built the PNC China Net. So far, we already established a partnership with over 90 teams across China. So according to this platform, we have a lot of international conferences. We invited the foreign experts come to China to share what they did, and we try to do the same thing. For the international collaboration, we have the first one, second one. So far, we have the number nine International Promise Conference. And we have an official website. So if you are interested, you can go into our website to see more introduction. And that's what we did. We have a WeChat account because in China we use WeChat most. So we have official WeChat account, and we update the research findings in this WeChat account. And of course, also we publish a book, a textbook in 2023, and this book was elected a good book in that year in China. And of course, based on that, we have a lab try to do the usability testing of the smart care. Tomorrow, or maybe in the next, the lecture, I will share more our research on the nursing informatics, something like that. So that's our lab. And Promise is just a tool. The most important thing is that use this tool to answer the research questions. So our team, our research team, get some funding supported to do the Promise related issues. For example, we got 49 provincial and different level research project based on that, and over 300 research papers published, and 21 software copyright we got based on this measurement. But they answer different research questions. For example, we give you some example about what we did related to the promise measurement issues. For example, development of Chinese promise, and also we built the Pro Data platform to do to get the promise cat. And of course, this cat, we have different type to help patient in clinical setting to use for example, for children, when we have different cartoon, the different way to help children to use these questions. And for the promise cat, you say the thing is for this measurement, we try to focus on the precise measure, precise intervention. So individual-centered measurement and the individual-centered intervention can be done based on that. So that's what we did. And say that's different different APP. So different informatic production can be designed to use this measurement. For us, we just guarantee the quality of the content of the Chinese promise. Okay, then we permit the applier to use the content. But for the user, they decide what kind of production they want to design to use promise. So they can integrate the content of the pro into their production. So it depends on them. So we built up a big pro China net. Okay, we hope. The more they use, the more precise the measure can be. So that's our goal. Then we did some symptom signs in cancer patients related on PRO. So treatment-related symptom patterns, because of the measurement included all the items, so we can did a lot of symptom net symptom pattern. We can figure out a lot of symptom pattern. We can draw the profile of the patient. So after identify the different pattern of the symptom, we can forward to develop a different intervention. So we got some funding, try to do something like that. For those are some my students. You say we can say construction and evaluation of pain grading and high-risk group early warning model for breast cancer patient based on patient self-report. And another classification, prediction of symptom management needs and precision serve strategies for young breast cancer patients from the perspective of online community. And for this one, development and clinical evaluation of visual assessment and precision management program for chemotherapy side effects in breast cancer. So, because of management, we develop a lot of research project. And next, okay. Say that's a symptom signs. So symptom heterogeneity analysis, symptom network analysis, symptom trajectory identification, symptom prediction models, symptom management knowledge graph. That's something what we did. So based on that measurement, we develop a lot of research. And also, for the informatic production, maybe later during this week, we have a lot of time to elaborate the research project. But you already understand what we are doing. So surrounded or based on the promise, we develop different, we encourage students or faculties across China, they apply for our center. to get our permission to use the measurement, then they develop their research. Okay, so we develop that's one of the example for children for the pediatric prom. Say that's the cartoon. What we did. That's the cartoon. That's the second. That's the first version. Then later we got version 2, version 3. So step by step. So in this area, we did a lot of research. I have another PPT to just focus on pediatric research. And another area of my research is for adults, for cancer, breast cancer, patient with breast cancer. Okay, then based on that, we talk about the new concepts and the theories in digital science. We in China, we are one of the group who introduce some concepts to nursing areas, such as patient profile, patient journey, digital patient journey become one of the very important concept in China now. A lot of PhD or master students draw the patient journey as a different journey. So hopefully, based on this journey, we can develop a precise intervention. And the digital triangle, that's the theory we proposed 3 years ago. So based on this theory, a lot of projects submitted. I will introduce this theory later. And also, we developed the data and evidence-driven health management platform. Okay, for the future plan, of course, we'll continue to construct our PNC China, and we are very hopefully in future we can collaborate with you. We compare how different culture influence the way patients express express their feelings, their experience. And we promote this measurement can integrate into the solution in clinical, and with the nursing informatic development, we hopefully we can conduct more promise related core technique. Of course, training help our professors pay more attention to listen to the voice of the patient and translate those voice into clinical decision making. Introduce patient into the health system to empower them, because the patient-reported outcome is one kind of data we cannot miss in our big data era. So that's what I'm trying to introduce, and hopefully in future our Fudan University and Indonesia University, a lot of students, a lot of thinking about the clinical questions, and that's working together to provide a new solution in this area. Thank you.
Thank you very much, Prof. Chang Ron Yuan, for the excellent and insightful presentations. The topic of digital health management integrating patient-reported outcome, it's truly fascinating, and especially it shows us how valuable big data can be in understanding patient needs, improving healthcare quality, and supporting more patient-centered nursing care. Okay, ladies and before it, I would like to make the audience more focused, I think. Just I would like to give some pantun ya buat Bapak Ibu semuanya di sini. Asik. Belum ya? Evidence based jadi pedoman. Jangan sampai fokusnya pindah ke notif pesan. Mari pusatkan perhatian karena ilmu dari Prof lebih penting dari scrolling diam-diam. Oke. In English, Prof. Phones can wait. Question overdue. Let's start 2 discussions. Over to you. Okay. Ladies and gentlemen, we will now move the question and answer for participants who would like to ask questions. Please raise your hand and mention your name, affiliations before asking your questions. We kindly request that each question be delivered briefly and clearly. Okay? And I would like to invite 2 professors to sit here because we will move to the discussion sessions. And from the online Zoom, it's also, there's so many questions. Okay. Okay. For everyone here, I would like to give two occasions to a person who would like to give an questions from Prof. Hu or Prof. Yuan. Okay. Anyone? Okay, 2.
Thank you for the opportunity. My name is Adang Manuel da Silva. I'm from stand up. I'm from Master Nursing Management and Leadership. I have a question for Prof. Huyan about the guideline CPR. In the case, as a lecturer, me as a lecturer too, teach a student about the CPR. And I use the reference American Heart Association. But in the hospital, the students are learned from the CI or clinical instructor from ASCOR guideline is a council from the Australian and New Zealand that they have a different guideline about the CPR. So in the American Association, as you said before that, now is different because of the evidence-based practice now is CAB. But in Australia and New Zealand, they still use, according to the reference 2020, is use ABC. The question is, different because of the context, evidence context, or the clinical expertise, or patient preference. And how can we decide to use the right one? Is there a way that we can use to decide the right one? I think this is the question. Thank you for the opportunity.
Thank you for the question. So we have the different guidelines here from the New Zealand, Australia, and some things. Which one will correct we will use in our daily?
Good morning, Professor. My name is Prima. I am a nursing specialist student and I am majoring in medical surgical. Professor, we are in the nursing specialization degree. We learn about how to implement evidence-based nursing, and it has become one of our tasks in nursing specialization degree. And I think it is very important to us for the student who will take nursing specialization degree after we are graduated. And also, I'm a clinical nurse, so it is very important to us. And my question is, although we have implemented our evidence-based nursing in last month, but I still have several confused because some hospital that we are plan to implemented our evidence-based practice there is have a different guideline. Moreover, for the determining the number of respondent, and also about whether ethical approval is necessary or not before we implementing when we want to implement evidence-based nursing. And then the second one is, do we need to obtain ethical approval before we implement the evidence-based nursing? Because as far as I know, my understanding is implemented evidence-based nursing is different with conducting an original research or research study. So what we have to do? Thank you.
Thank you for the question. Okay, give applause for the 2% that give the questions. Okay, Prof, the floor is yours.
A very good question. Two very good question. And I think that's questions normally for our nurse practitioners may ask when they hear about implementation and hear about evidence-based healthcare. Really very important issues we have to clarify before we implement evidence into practice. The first one, Adam. Is that Adam? Yes, I asked her. Thank you. Yesterday, you pick us at midnight. Thank you, and Riven as well. For the guideline, there will be many different guidelines, and the different guideline proposed by different organizations. Someone like CPR guideline from American Heart Association, AHA, is very like well-known association, and they produce a lot of things like well accepted by health professionals. CPR guideline is the one tradition, but that one update based on current best available evidence from the searching from the like current systematic review based on primary study. So update based on primary study. The one from ABC to CAB based on primary study and the systematic review. Because of 这个心源性 heart from the heart failure, the acute heart failure, we need to like drinking, we need to have circulation first. But for the one you mentioned in traditional, we have ABC, that we consider a lot of our airway obstruction. So if the case is airway, the heart stop beating because the event because of heart failure, because of like exercise and then fall down because of the heart failure. That one, circulation is very important. So for the one for AHA, the mentioned CAB is only for those heart failure related event. So I think evidence-based practice is go back to the definition that best available evidence and the clinic context. So in the clinic context, for the context of like acute heart failure, CAB is so important. Circulation first. But if the situation is because of the drinking of the breathway, so airway is important. So there is no conflict because their concern is what is the cause of heart stop beating. So I think there's no conflict. So when we consider all these guidelines, if we read this guideline and then pay attention to their circumstance of the guideline, the evidence proposed, then there is no conflict. That's professional ways to make different circumstance and different interventions. Yeah. So that's the first question. Okay, and the second one from our second student, master student, is about ethics. For implementation study, whether or not we need to have ethic approval, it is evidence, it is effective from the guideline. When we implement it, do we need to have the ethic approval? The answer is yes, we need to have, because it is research. Because of we consider the patient outcome and also implementation outcome. For the implementation outcome, there are a lot of interventions are different from the traditional way. So when we make change, like the reporting system change, have the ethic, especially for patients. So ethic is really a very important issues in research. As long as it is research, we need to have ethic. How many participants? Just like research, we need to calculate the effect size. So similar to primary study, we have to calculate the effect size. We have to go through all the process of research. Thank you. Did I answer your question?
Okay, thank you. And maybe Professor Changran will.
You need to create an intervention too, which means that you need to after figure out the factors which influence the good evidence applied in clinical setting. You I mean point to those problems. You propose the solutions. Then that's become a primary studies, which means that you develop an intervention. We call it implementation intervention. Those interventions have a different outcome to measure their efficiency. From this point, yeah, we need to do the apply for the essays permission.
Okay, thank you for the adding question. Sudah menjawab, Kakak ya? Oke, baik. We will move to the questions from online. I'm sorry, just there's so many questions in the online session. First from Imami Nurrahmi to everyone. Question for EBN. Could you repeat what's the appropriate design for EBN implementations? Maybe Prof. Hu or Prof. Chandra.
Okay. For implementation study, the design can be traditional ways design, but more appropriate ways is adaptive. We call adaptive design, using step-weighted design or non-randomized control trial, or like a randomized controlled but wait list trial. Randomized control, but wait list. That means the control group will go to the intervention. So that's the randomized control trial wait list design. Or step weight that goes step by step. So that's different design.
Okay, for Ibu Imami, apakah sudah menjawab, Ibu? The second. Okay. I think I hope the answer is sudah menjawab. Okay, for the next answer from Muhammad Jauhar, the question is thank you for Prof. Hu Yan for your inspiring presentations. I am Jojo, a doctoral nursing student from Universitas Indonesia. My research focuses on improving the quality of life of older adults with dementia and in nursing homes. Given the most intervention studies are conducted in hospital and community settings, and considering the significant differences between nursing homes in Indonesia and those in other countries, what approach would you recommend for identifying and best determine the residents' preference and needs when designing such interventions? Okay.
Okay, that's very good questions. Yeah. Because for hospital setting and nursing home setting are very different. For us, are so different because in nursing home, the healthcare provider we call just like nurse assistant, not registered nurse. Most of them are nurse assistant. So their compare with registered nurse is different. For the implementation in nursing home, we are conducting food ulcer prevention for diabetes elderly in nursing home, and also fall prevention in nursing home. So all these projects, when we have the successful project in hospital, but in nursing home, the situation is very different because of the staff, the one who directly provide care. Their level of knowledge and attitude and behavior are different from registered nurse, and also the healthcare system in nursing home is different from acute hospital. So the implementation is so different. We provide a lot of trainer for health providers, nurse assistant. And also we do a lot of like easy ways, easy education like pamphlet and education tools to nurse assistant, to assistant nurse. So education is different from the one in a hospital, and also the evaluation of the process and the model of education is also very different. In nursing home, we provide training during the lunchtime, because that is the only time for them to have time to get together. So we provide lunchtime, and also we put a lot of reinforcement, like we give a lot of like evaluation, but like inspiring, because for them there's so many people supervise them, the nurse assistants, there's so many people supervise them, social workers and the nurse and the managers supervise them. So they think it is so burden for more people, like researchers come to supervise them, ask them to do something. So they feel it is not very willing to join all the project. But the inspiring things is we have the training and we have the certificate and we have the encouragement or the promotion integrated all this training with their promotion system. Like the certificate we provide, like for prevention or food ulcer prevention, it is related to the performance of nurse assistant in the nursing home. So that way they consider it is very important task or very important responsibility for them to be promoted. So different strategies in nursing home, different strategies in the different contexts, really very important. I think in nursing home, it is a praise for our healthcare accessibility of the high quality healthcare. We need to put more emphasis on nursing home. That is the praise we need evidence in. Thank you very much. Very
Okay.
good question.
Okay, Muhammad Jauhar, I think is just with us. Maybe Prof. Chandran will adding the answer. It's okay from Muhammad Jauhar.
I add something about that question. So let's return back to your research purpose, which means you want to create an intervention to improve the quality of life of the patients. I mean, in hospital or in home, at home. That's different. For implementation side, so should started with that you have a good evidence, which is efficiency in hospital to improve quality of life, or a good evidence to improve the quality of life at home. That's two different evidence. For the evidence suitable in hospital, you may say that's a good evidence when we apply it in hospital, which will help patient to improve their quality of life. But the thing is, some nurses in some hospital won't use it. So what's wrong? So let's figure out what's wrong with nurses' knowledge, the policy in this hospital, the resources support in this hospital. Then we create implementation intervention shoot in hospital to use. That's one research. The other research is at home. That's different evidence. So those are totally different. Then we can separate this research into two different research because they serve two different research purposes. So I think when we talk about the research general picture, that is, we start from the question. Then later, we find a good existed evidence. Then we continue to ask whether this good evidence cannot be applied in your setting very well. Then we found the problems. We provide a new solution for these settings. Am I right?
Okay, okay. Thank you. I think it's very complete answer. Okay, to the next question from Siti Nurlela or Ella from Rumah Sakit Cipto Mangunkusumo. Thank you for Prof. Hu, Yen, and Prof. Yuan for the presentation. My name is Ella. I work as a nurse manager at Cipto Mangunkusumo Hospital. I have two questions. One, could you share how your university and the teaching hospital collaborate in conducting research dominantly to implement evidence-based nursing practice on hospital floors? What policies available in terms of China context? And the second question is there is a specific career stream for a nurse researcher at China hospital? Maybe you can share the experience at the China. Okay.
Collaboration.
Yeah.
That's a very, very good question. So, also, still, we continue to explore good answers because there is no standard answers for this question. You know, one way is policy driven. The other is the research project driven. Okay, for the first the pathway, like our dean, we will set a very good organization policy, like the head nurse in hospital will become our vice dean or some teacher. They have some rulers in our hospital, in our nursing schools. Then from this official organization, we like force push their collaboration for faculty at nursing school. We have to take a time to go to clinic to find the questions and to guide them and do some clinical teaching. And for nurses in hospitals, we invited them to in charge of some courses. They come to the nursing school. They deliver the course. So by this official organization policy, the collaboration developed. And the very important thing is that our master and PhD education. Because our nursing school in charge of all the process, like recruitment, like a middle term, the report, and defense, the CSIS defense, all those training activities will be organized by our nursing school. So through this very important activities, we do the collaboration. That's part one. Officially, organization support. The part three, just the we do it depend our research preference. For example, my research major focus on the oncology cancer care. Then we have a lot of project working together with nurses in the cancer hospitals. So project driven. And recently in our university, the whole university encourage the multidisciplinary team to establish. In our team, we invited faculty from the foundation, the medical school, and we invited the physician, we invited the engineer to join our team. So every season, the university will do investigation to say in your school what's your needs, what your needs to for our university to help you to linkage to other discipline. So every season we have a book, a list. We have a list to announce, like teachers from nursing school, what you need, and nurses in hospital, what you need, and the university will try to match them and introduce them to know each other. Then encourage the collaboration. In conclusion, there is no standard answers, but research project dreaming, I think, is the future. So we need to return back to the research questions. If we ask the research question in real world, which should both sides or three sides or different parts working together, then let's do it.
Okay. Thank you for the answer. And the second question.
I think Professor Yuan has mentioned the very critical
Mm.
core element of collaboration. That's the interest and also the link, the funding of partnership. And for me, I think the resource allocation is the mechanism for collaboration. The resource allocation. This resource, not only money is the resource, funding is the resource, but others, policies, and also motivation of their interest. So that's the resource allocation is the mechanism. Like what Professor Yuan have mentioned, we have the money, we have the funding, the grant of a hospital or affiliated teaching hospital and or nursing school can apply for fund together, and we encourage them to collaborate to apply for funding. If they collaborate, you can apply for more funding. If there's no collection, it's little funding or no funding. So that's the funding mechanism. And another one is also like people promotion. If they have collaboration, they can have more resources. Like here now is our 5-year strategic planning. This period is 5-year strategic planning. So when we do the strategic plan, we put a lot of emphasis on the collaboration of team, of multidisciplinary team, especially for hospital and also nursing school. Like cancer care is the Professor Yuan leading the group of cancer care. But for cancer care, it's not only Professor Yuan's members in cancer care, but hospital in cancer hospital and other hospitals. There are different peoples from cancer care organize a team, and the resources are allocated to Professor Yuan as the PI. But Professor Yuan might have a lot of like project to contribute to the main goal, and then have different project, have this like the whole quality of life improvement goal. So that's the mechanism of resource allocation, not only money resource, but others, policies, and also human resources. So I just add one thing from
And
the organizational.
okay, in specific career stream, maybe in China.
Sorry.
The second question, this is about specific career. Sorry, yes.
A career stream for research, nurse researchers in hospital. I think that's very difficult for researchers because clinic is clinic specialist, clinic nurse, focus on clinic activities. But research, is it the major responsibility of nurse? A lot of nurses don't believe research is their major responsibility. They found quality of the clinic care is very important. But the main things for clinic nurse in China's hospital is their health promotion, their career promotion. For the goal of or the requirement of career promotion, like from we call nurse chief nurse, major chief nurse to chief nurse, their promotion of career promotion need to have research. So that's the requirement of the career ladder. Research is in there. So that's the way to make career research nurse as one of their tasks. Research as one of their tasks. But for research, majorly in research nurse, actually we don't have that nurse, that majority or a major role is in research. So they are doing clinic as the major responsibility, but research as the additional role to make their task as better. So we actually currently we don't have, we call research nurse. We don't have that role. But in the clinic trial, the big clinic trial, from initiated by physicians or initiated by companies or initiated by like nurse, during that very specific time, we could hire or to recruit some nurse in that specific time, just conducting CRN clinic research nurse, CRN role. So that's a very specific time to conduct research, to collect the data and to supervise or to assistant with the project. But that's not the continuing role, just one period of time, and they get paid by the clinic though.
Okay. Thank you, Prof. Hu, for the answer. And we are moving to the next questions from Umi. Dear Professor Hu, thank you very much for your inspiring presentations. My name is Umi, doctoral students from Faculty of Nursing, Universitas Indonesia. Thank you for the opportunity to ask these questions. I'm very interested in your explanations about how to implement EBP nursing before implementing or adapting findings from systematic review or result of meta-analysis, if there are still limited experimental studies about the implementation, but several published studies show significant results, would it still be appropriate to implement the evidence in practice, or do you have any other suggestions or tips regarding these situations? In addition, how can we address challenges or barriers when implementing evidence using the PPOS D method? How can we adapt or transculturally integrate it, the implementation with local culture so that it can be more easily accepted and adopted? Thank you very much. Yeah, it's a very long question.
Process of
Okay.
Thank you for the very good questions. For that, I think tomorrow I will share some of the process. We encounter the same problems here, like the cultural barriers and their traditional ways of practice. So how can we implement if the evidence is not strongly enough, whether or not we could implement? So remember, when I mentioned implementation, I said there are three assessments. One is the situation, the context assessment. That's the needs assessment. And the second one is the gap assessment, the evidence and the clinic, whether or not there is gap. So when we assess the gap, the evidence, we should assess the evidence, the strong needs of the evidence. Even the evidence is very strong, it might not be appropriate for one culture, like DNR. When we do not resuscitate in palliative care, we have do not resuscitate. But that one is not applicable in Chinese culture because people don't want to talk about death. They want to talk about life, going survive. So that's the things, cultural things. Even for the family providers, family members, they don't want to talk anything about death. They want to talk about all the things about saving life. So I think that's a lot of cultural things. The evidence is not very strong in Chinese context. When we want to like promote palliative care, we have to like discuss that evidence with our family members and the patient and also health professionals to get the improvement step by step. So the evidence is not so strong here, but we are trying to find what is the barrier or whether or not we could step by step get people understand the quality of life and the quality of death, how important it is, and how to step by step fit the needs. So I think that's not the go quickly way. That's the go step by step ways. And to analyze the situation, analyze the context, and analyze the gap, and to find the strongest or the level of evidence, and then try to find some solutions. So gap analysis, context analysis, and then finally frame analysis, the feasibility, the strategy, whether or not it's feasible. So the three analysis is very important for implementation.
Okay, okay, because we have the limited time, so I'll continue for the next questions. Thank you for the great from Neni Malkis. Thank you for the great explanations, Prof. Hu and Prof. Yen. I want to ask to Prof. Hu as a nursing resident. I often find it long established clinical routine. Based on your experience, what are the most effective strategies for successfully transitioning to evidence-based nursing while minimizing resistance among senior healthcare professionals?
You have
Yeah.
the long established clinic routine. So what is the most effective ways to transition of evidence-based practice while minimize resistance? They need to have a lot of strategies to minimize the resistance. This resistance sometimes is very strong. The most effective ways is to make the system understand the benefit of change. So everybody, if understand the benefit of making change, then that's the first step to make the system get loose. Otherwise, the resistance is very strong. So during that phase, unfreezing phase, we don't do anything for intervention. We just a lot of discussion or seminar or workshop or evidence interpretation, just sharing, just like today. I talking about the evidence, how it is effective. I share the clinic studies, how it is conducted, and what is the rigor of the study, and what is the outcome. So I don't want to make change, but share with the evidence. What is the evidence coming from, and what is the design, and how benefit it can make to the clinic practice. So that's the stage, unfreezing stage. Don't do it at very quick way. Don't make the change right after you find the evidence. So making change step by step, unfreezing, and making some step by step change, and then make it stabilized.
Okay, so step-by-step processes, Prof. Yeah. Okay, for the next question from Ibu Dewi Gayatri, thank you very much for sharing this extraordinary material. My name is Dewi Gayatri from FIK UI. I would like to ask the Prof. Changron a few questions. First, the promised instrument does not include a spiritual aspect. Is there specific reason for this? And the second one, I'm very interested in the project being developed. Can you show us how the promise information system is implemented by team? Thank you very much.
Thank you. Very good question. And when the promise developed first, it's in 2004. So they use a very big frame. So for this frame include three parts, three dimensions. One is physiological, psychological, social. So for the spiritual aspect, we can find, in these three big frame. Okay, so maybe use different name of the definition, terminology, but it's under these three big frame.
Okay.
And how to use it,
tomorrow I'll show some production. For us as the PNC China, we focus on the Chinese version, the content. We guarantee the translation, the culture cross, the testing, something. We guarantee the content. But for the way to use depend on different team in their own hospital. Maybe you can use integrated into your electronic the health record, different system, or at home you can use the cell phone. So you can explore your own solution to use that.
Okay, okay. Thank you for the answer from Prof. Changron. Okay, can you have attention, ladies and gentlemen? We are moving to the next questions from others. Okay, from Fuad Mubarak. In modern cardiopulmonary resuscitation, the RCAB, as recommended by the American Heart Associations, the letter C represents chest compressions, not circulation, highlighting the importance of early initiations of compressions to ensure adequate cerebral and coronary perfusion. Okay, thank you for the maybe some informations that gave to us from Nurse Fuad. Okay, maybe just two questions left, Prof. Okay, for the next question is from Fanny Amdayani. Thank you so much for the wonderful presentations, Prof. Hu Yan and Prof. Chang Rong Yan. I'm Fanny Amdayani, a Master of Nursing student in Medical Surgical Nursing. I have two questions for Professor Hu Yan. China has made an incredible transition into tech superpower, driving cutting-edge AI in healthcare, yet historically your country is also deeply rooted in TCM. Looking at the implementation science and the no-do gap you mentioned, how did China actually use context and gap analysis to handle the natural tension between modern evidence-based science and those deep-rooted traditional practice? Did the system manage to embrace and integrate traditional practitioners instead of leaving them behind or marginalizing them? Okay, maybe answer first.
I think that's a very good question, because I think in Indonesia, there are a lot of traditional Indonesia medicines, so ways of traditional ways that have long history. And the empirical indicator is, it is effective in some way, but for the traditional medicine, like in Chinese medicine or Indonesia or other country traditional medicine, normally there is no experimental study. It's the traditional like clinic outcome shows that it is effective in specific patient. So that's the traditional way, individualized. But the scientific, but the modern research need to consider the mechanism from from the municipal level or genomic level. That's the way to make it like apply in different situations. If we know the mechanism in the municipal level or genomic level, it can make it implement in other situations. Mechanism is very important. So for the traditional medicine, Chinese or traditional Indonesia or other country like in Thai, I know Thai, a lot of our colleagues from Thai, because we have a collaboration, there are also a lot of traditional ways, and they are conducting the scientific research to find out the mechanism. Like the acupuncture in China, we have a lot of lab study on the mechanism of acupuncture, the point and the like the way you in massage. So we are conducting a lot of modern research to identify the mechanism and try to make it applicable to other situations. So I think that's the combination of traditional ways and also modern approach. But that is only the process. But we actually, for us, it is so strongly embedded in the tradition. And there is a lot of stories about how traditional Chinese medicine herb is affect that story. So actually in modern science, we don't make the decision that it is not scientific, or it is scientific or not scientific. We just leave a room for our scientific, like science part to verify it, use the scientific approach. So I think we don't make the judgment on whether or not it is effective or not effective, but just leave a room for a scientific approach to verify it, and then make it applicable to other situations. So, yeah.
Okay, thank you for the answer. And the last questions from Feni Amdayani for Professor Chang Ron-yan about digital health management and promise. I am very interested in your smart care usability lab. What would you say were the biggest clinical or technical hurdles your team faced when trying to blend subjective patient-reported data like pain intensity with objective clinical findings? Also, since Indonesia also relies heavily on traditional treatments and is currently building its own digital nursing landscape, what is the most important lesson we should look out for from your platform's journey?
Thank you. Very good questions. You know, you know, when you have to listen to somebody's voice and try to introduce their voice into your decision making, it, I mean, cost your energy, cost your time. So sometimes the most difficult, most of the challenge is that physicians don't want to do that. They don't want to, you know, they think it won't help them a lot. So we need to have to reduce their burden. We need to let them find the benefit from listen to the voice of the patient. For example, if some voice be listened, then we can give a different diagnosis. For some pain, send some evidence for them to guide, to help them. Then that's I mean, the low risk level. But for the I mean, after listening to the voice of the patient, it will help you to figure out which are the real risk, which are not. The thing is, the whole system can benefit from the voice. Then they will help to listen to the voice. The other thing is that in order to reduce the benefit in future, currently we have to cause the benefit during our research journal. So when our students do the study, they have to, you know, use a long list of the items. So the reviewer often asks, how long will it take for patient to do that? But that's the process, because we need those data to help us to reduce the burden in future. The data, after we figure out the rulers, the linkage rulers, then we precise for the future patient. So during that the process, yeah, we thank very much for our patients who want to apply for that. So that's I mean, cognition, the knowledge change first. We need to include the patient join in. We need to find the benefit. Then in future, those data can be included into the health system.
Okay, thank you very much. Give applause for the two professors here. Okay, ladies and gentlemen, we have now come to the end of today's session, academic sessions. On behalf of the committee, we would like to express our sincere gratitude and the Honorable Dean of the Faculty of Nursing Universitas Indonesia, our distinguished speaker, Prof. Hu and Prof. Yen, to invite the Dean, this both speaker, and everyone's here to take open the camera because there is so many participants at the Zoom. I think it's about 200. Oh, it's one. Woo! It's very 185. It's 185 participants from all nursing in professor maybe come. Oke. Untuk Bapak Ibu yang ada di room Zoom, mohon untuk membuka kamera dan merapat untuk kita foto bersama. Mumpung ada dua profesor kita semua di sini. Silakan ada yang di bawah juga sini menemani. Ada yang di bawah biar muat. Ada yang di bawah, monggo Bapak Ibu. Let's go. Yang di kamera Zoom boleh open the camera. Oke, Ibu pelan-pelan, Masya Allah. Silakan. Abang maybe here. Prof. Monggo, silakan Ibu saya. Aku di pinggir aja. Sini aja, Kak. Ya. Oke, di bawah lagi. Ayo, kita di depan aja. Ayo, Bu. Oke, aduh maaf ya. Oke, mohon berhitung ya, Kak. Ya. 1, 2. Kayak apa nih? UI. Melesat dulu. Oke, melesat. It's like that. Melesat banget. Ya udah UI aja gimana? UI. Prof, we have UI code, Prof. Like this. Oke, gaya bebas, silakan. Oh, melesat dulu, silakan melesat. Freestyle. Okay, thank you very much. Give applause for everyone here. Thank you. Yeah. Okay, for everyone. Like to give announcement from to all the audience. First, another agenda of Professor Hu and Professor Yen is held on Wednesday, 3rd June 2025 at 9 to 12 a.m. with the topic take place in the classroom, 4th floor, Education and Lab Building, Faculty of Nursing, Universitas Indonesia. In the second agenda, saya akan mengumumkan beberapa agenda lanjutan Bapak Ibu sekalian. Pada tanggal 3 Juni jam 14 sampai jam 16 akan ada topik lagi workshop ya dengan judul Implementation Science and Implementation Study Theory Design and Method di gedung lantai 4 juga di Universitas Indonesia. Dan untuk agenda terakhir dari kunjungan profesor hari ini yaitu di tanggal 4 Juni 2026 nanti akan ada di room 212 di gedung RK UI juga. Ya, Bapak Ibu tamu yang saya hormati, izinkan saya untuk menutup kegiatan hari ini. Saya selaku moderator mengucapkan terima kasih yang setulus-tulusnya atas atensi dan perhatian dari Bapak Ibu sekalian. Thank you for the Professor Hu and Professor Chang Ron-yan for the best inspiring lecture here. Mohon maaf apabila selama kegiatan ada kekurangan, ada kesalahan yang kurang berkenan di hati Bapak Ibu sekalian. Wassalamualaikum warahmatullahi wabarakatuh.
Recording stopped.